This conference will now be recorded.
Excellent. Well, welcome everyone to this, the final seminar of the Ideal for RWE training program. I'll say a word about that in a minute. But today we're very excited to have with us Dr. Dave Leather, who will be talking about efficacy and effectiveness. Now, there's a dilemma. Just a couple of housekeeping points before we start. There are a larger number than usual of us on this call than we've had on some of the previous ones. I would really appreciate it if people could go on mute, and we may automatically mute you if we need to, just so we don't get distracted by any background noise. Can I draw your attention to the team chat functionality on the screen as well? We will be using that. You can use it if you've got any technical issues that you're struggling with, but we'll also be using it for some questions that Dave has for you. And it'll be one of the ways in which you can ask questions as well during and particularly at the end of Dave's presentation. So just a word about Ideal for RWE, because I know not all of you have heard about this. This is the IQVIA DIGICORE Early Career Leadership Training Program for RWE. And over the past, I think probably the best part of 9 months now, a brave cohort of clinicians, data scientists, researchers in cancer from across Europe has been going through what we hope has been a really interesting and challenging program. We've had a series of seminars, of which this is the 6th and last. But given given the relevance of this topic and the interest we know it has for many of you, we've actually widened the invite beyond the immediate cohort to the broader DIGICORE community and friends and family. And to those of you who are relatively new to this, I would say welcome. I can see some old friends from IQVIA days as well. It's nice to see you here. And just also to mention that whilst the kind of the Ideal for RWE chapter is moving towards an end, we are going to be having a series of masterclass lectures based very much around some of the work we're doing with DigiOne and the technology infrastructure implementation and clinical studies that we'll be doing as part of that. So please do keep your eyes peeled, follow DigiCore on LinkedIn if you don't do already, and you'll get a sense of some of the other interesting and exciting discussions that we have coming up. So, but let's bring it back to today. It's my very great pleasure to introduce Dave Leather. First met Dave in September last year, where he came to speak to the very first of the IQVIA, of the Ideal for RWE leadership retreats in Paris. He gave an excellent and very thought-provoking presentation then, and he kindly volunteered actually to sort of follow that up with the presentation we've got today. Dave's a former GP, spent much of his career at GSK in the respiratory and HIV franchise there, and certainly to me, the thing that his achievement that I'd heard of and was of particular relevance was his leadership and involvement with the Salford Lung Study, which is a very well-known and influential real-world pragmatic trial in inhaled asthma products. So he's got long and deep experience of working in RWE and, lots to share with us, I'm sure, about how that fits together with the world of clinical trials. So Dave, I'll hand over to him in a second. He's going to talk for about half an hour. Please feel free to line up your questions in the chat and also take the opportunity to respond to some of the questions that Dave's is asking us. And then when he's finished, I'll do my best to kind of compare and coordinate a bit of Q&A as well. We will have plenty of time for that. So I'm going to go on mute now and I'm going to hand over to Dave. Thank you very much, Dave, for speaking to us today.
Thanks very much indeed, James, and thanks for the invitation actually to do this. It's a topic I love and find of great interest actually, and hopefully I'll be able to share some of that enthusiasm with you. To kick off, these are my disclosures of conflicts of interest. The key thing being I retired from GSK in January 2022. I guess that's quite important now. So a bit of a disclaimer about this presentation and the talk I'm going to give. So it's designed to be thought-provoking and reflective, really, not to give you answers. And the reason for that is this is a field where I still think there isn't uniform agreement on how efficacy and effectiveness fit together. And I'm hoping that I'll sort of uncover some insights about that. I think the maximum value from this session is to reflect on your experience, your research, how this framework fits in with what you're doing, and maybe learn or think about issues that may touch the work that you're doing. A lot of this is referenced, and the references on the slides, but a fair chunk is anecdotal and illustrative. I mean, one of the things I've found now I retired from GSK is I can be a bit more anecdotal and tell some stories. I'm going to protect the innocent, don't worry. But hopefully that'll bring it to life, I think, some of the things that we believe and think about, and maybe challenge our thinking a bit. And then finally, a bit of an apology, because most of my career has been spent in HIV research and in respiratory research. Little has been in oncology. And so, you as the audience will need to bring that perspective to the discussion. But I'm going to be using a large number of respiratory examples, which are the things I know best and had closest to hand. So what I'm going to cover in this next sort of 30 minutes or so is firstly talk about evidence hierarchies, because really that is one of the areas where there are dilemmas. Talk about definitions of efficacy and effectiveness and think about the history of them. Just briefly look at a few anecdotes. And then the key question, I think, very often is, who is the evidence created for? What's the intended audience for your evidence that you're creating or for the research you're generating? I'm going to touch upon drivers of effectiveness. Ask the question, do different approaches, efficacy and effectiveness, give us different results? And then really a brief wrap up at the end. The photograph on the right hand side on this slide is actually the part of the team that drove the Salford lung study, which, as James said, was a really big 9,000 patient pragmatic trial done with a pre-licensed medicine. It was the only one of its type, really, I think, that's been done. But it was a big endeavour I was a part of, and I did lead a real-world evidence group within respiratory medicine at GSK. So I'm interested in thinking about evidence hierarchies now, and I'm going to ask you to use the chat function to order these types of evidence in what you would consider their significance and rigour. So the different studies types I've got here have all got a number, so all you need to do is put the first two or three that you think are the most important just by their numbers, okay? So number one is case series and reports. Number two is case control studies. Number three is meta-analysis of double-blind randomized controlled trials. Number four is double-blind randomized controlled trials. 6 is randomized controlled trials, and 5 are cohort studies. So just as you're sitting there, think, what would you put top of the pile in terms of a hierarchy of evidence? And James is going to have a look at the scores as they come up. I'm going to briefly go on to look at evidence hierarchies in a second or two. But just see if anything comes up. Anything coming up yet, James? Or
Yes, we've got an early leader, which is the meta-analysis.
yeah,
Quite a bit of consensus that in second place would come the double-blind RCT. A bit of an
yeah.
outlier there. We've got somebody putting the RCT number 6 first. Somebody's going for double-blind RCT in first place as well. But certainly 3, 4, and 6 in various configurations are at the top of the tree.
Okay, I mean that's pretty much what I was expecting, and it is exactly what I would have put, I think. And what you'll be pleased to hear is that if we look at reviews of evidence-based medicine, and I've taken this example from the BMJ from 2016, it's pretty much exactly the order that you've come up with there. Systematic reviews, meta-analysis of double-blind randomized controlled trials, RCTs next in general, case control studies, and series or reports at the bottom. So this is quite interesting to me, because you have to ask yourself, why did we make that decision and that ordering? And I'm going to come back to that theme throughout this, because I actually believe that this is because of our medical training and the influences that we've had in terms of scientific rigor. Now, if I asked you a similar question again, but different, which is to say, if you looked at these types of evidence now and said, which type of evidence do you think would inform you best of how a patient in your clinic would respond to a treatment? So, the question I'm asking here is a patient that you usually see sitting in front of you in your clinic in the type of work that you do, would the answers be the same or different? And you don't have to order them this time. I just want to know if you can put in the chat same or different. I'd be just interested to hear that view.
I actually have got some people coming through with some numbers as well, but
Yeah, okay, that's
um,
good. Yeah,
yeah, there is a consensus. Certainly, we haven't got anyone saying the same. Lots of people saying different.
yeah,
Um,
yeah,
in terms of the specific numbers coming up, cohort studies actually.
yeah,
Uh,
yeah. I
a,
mean,
a
good to hear. Carry on. Sorry, James.
No, and actually somebody's plumped for even case series and reports as well.
Yeah,
So
yeah.
case controlled studies as well. So actually the opposite of 3, 4, and 6.
Yeah,
1, 2,
and I
and
think
3.
this is something that dawned on me. Originally, I was a real zealot on evidence-based medicine. I was once very involved with the Royal College of GPs and used to go out on road shows talking about evidence-based medicine. And I'd become a bit obsessed with the double-blind randomized controlled trial, and in addition, meta-analyses of those. And I'm just going to, over the next sort of 20 minutes now or so, just reflect on a few thoughts about those things. And it is going to sound like I'm, having a go at double-blind randomized controlled trials. I'm not at all, because most of my career has been actually in developing those. They are essential, but there are some questions that tell us that they don't always tell us what we really need to know about clinical decision making. Now, there's different ways you can think about real world data and how that fits in with evidence hierarchies. And this was a paper that I found that I thought was really thought provoking, because it sort of helps us think of study designs in a different way. So, on the y axis here, down the left hand side, we've got the population, and at the top, whether that's a broad population, at the bottom, a narrow, highly defined population. So at the bottom, that would be very pure confirmed diagnosis, and at the top, it would be conditions being managed as if they had a diagnosis. And along the x-axis, we've got the ecology of care, which on the left-hand side is very highly controlled and constrained, and on the right-hand side would be free. And so we can start to think of how studies may fit into this framework, in that a very highly controlled study done in a very pure diagnosis would be a typical registration study, and typically a double-blind randomized controlled trial. Right at the top end, at the top, observational studies, where it's purely observational, maybe using electronic health records. That's the ecology is just observation. The diagnosis is not pure. Generally speaking, we're looking at patients who are being treated as if they have a diagnosis, and we don't seek to prove or question or challenge that. And then in the middle, we've got longer term phase 3 studies, pragmatic controlled trials as some examples. But I must admit, when I read this, I sort of thought this is helpful, because it sort of slightly changes the language we would use in describing studies, and I think stops them being in competition but sees them being complementary. And the same authors of that paper started to describe studies within that framework to sort of bring it alive. Down the bottom left there is the typical double-blind registration trial, highly controlled. Top right is a cross-sectional survey of self-reported asthma diagnosis, could be a telephone survey, for example. And in the middle, pragmatic comparative double-blind trials. And the Salford lung study was probably a comparative open label trial. It was randomized, actually. But you can start to put studies within this framework, and I think you can understand that they complement each other. And I thought this was smart thinking, and gave us a new language, actually, to think of how we might think about study designs. Now, the sources of real life data are obviously many, and with the advent of electronic health records, things are really changing. Databases, chart reviews, population surveys, pragmatic trials, cohort studies, and registries in particular, which oncology, I think, were really the pioneers of registries that have been incredibly useful to get to real life data and more pragmatic evidence about effectiveness. there's many different ways we can gather it. I'm just going to talk for a minute about some informative anecdotes. These are all stories that I've collected. They are based on the truth, though, and this is really a bit of a challenge to our conventional way of thinking. I mean, it occurred to me in my medical training that um, I'd been trained to believe that double-blind, randomized controlled trials almost gave you the scientific truth, and that they were so highly controlled and so pure that they were unquestionable. And of course, we have p-values as well, which are another strange thing that we believe in. P equals 0.05 and what that means, and we almost take it as truth when actually it's based on chance and it's a figure plucked out of the air. It hasn't been given by God, but we have this belief in these things. But as I started to work in drug development, I started to think about controlled trials and had some experiences that really made me think about them even more. So when I was working in the HIV Centre of Excellence for GSK, I was involved in a double-blind randomised controlled trial of a new antiretroviral agent, and the patient who was in front of me, or the subject in the trial, was who you would think would be an ideal subject. He was a physician who's 38 years old, very knowledgeable about his own disease and therapy, very keen to help science, and he was in a trial of a new therapy. But as I got to know that subject, he started to confess to me that he hadn't actually quite stuck to the protocol, even though we believed he was. So he was one of the people who suffered with facial lipodystrophy, which, as you know, with the early antiretroviral agents was a terrible side effect because it was so visible. And on the right-hand side, you can see the faces of some people who had that. It was almost a badge that you were on treatment for the disease. It was awful. It affected people's appearance. And it was something that many people wanted to avoid. And this subject, this physician, wanted to avoid that. And he was very, very keen to try to find a treatment where this would not happen. He also, even though he was a physician, had decided to take a drug holiday while he was on the trial without telling the investigators. And this was because at that time there was a craze of patients attempting to get their viral loads down in trials and then try and reinfect themselves with wild non-resistant virus. Now, this was a hypothesis that was, had no validity, but this was done. And this patient actually did this whilst in a trial. And of course, he wanted to appear compliant with the protocol because at that stage, this was a life-threatening disease, and most of the new drug opportunities came through trials. So it made me think that in our attempt to sort of control and monitor patients, there are other motivators and drivers that affect their behavior within trials. And these things strike me as being, worth thinking about because these trials are not always as tightly controlled as we believe. These are extreme examples, but they are real. These happen within trials, and they probably happen more than we think, even though we believe these trials are the truth. Another study I was involved in asthma therapy, I think this is quite a well-known one, was really looking at electronic inhaler devices to monitor adherence over time of a study. Now, these devices in the early stages were able to integrate not just the number of doses taken, but the timing of the doses. And the patients knew they'd consented that they were being monitored by this device. And yet still, when the downloaded data was looked at from the device, quite a large number of patients had discharged their devices whilst they were sitting in the car park prior to a study visit and actually discharged the right number of doses. So say we're expecting the patient to have taken 60 doses over a 30-day period, they would discharge 60 doses while they were sitting in the car. And you sort of think, well, even when patients are monitored, strange things can happen. And recently I came across another example of a study that was more pragmatic, but this was patients who were being brought into hospital to stabilize their treatment and get regular medication before they had treatment changes with respiratory disease. And in that study, even when the patients were in hospital, they often failed to get their doses of medicine. So it's very, very difficult to make controlled trials really controlled, because patients will still do, and investigators will do, things around these. I'm not saying that this is fraud, it's not. It is just when you do a lot of studies, you realise that it's very, very difficult to get studies as pure as you can. Now, the third patient I'm going to look at is actually my mum. Now, my mum's died now, sadly, but on the right-hand side is the picture of my family. So I'm the snappy dresser in the yellow jumper. I think I was 7 years old. There's my brother, my two sisters, and my mum. My mum was a nurse, a very senior nurse. She actually took a degree in nursing, one of the first nurses to do that. And as she got older, she developed osteoporosis, and she was very keen to help with medical research. And she'd been involved in a number of trials of bisphosphonates. And she knew from experience that she got GI side effects when she took the bisphosphonate. Well, she enrolled a trial in Manchester, was a subject in that trial. And I was chatting to her one day, and she said, "You know, Dave, I know that I'm in the placebo arm because I'm getting no GI side effects. So you know what? I don't think I'll take it. I'll just pretend I've taken it, and they don't need to know. I'll just carry on." And this is an interesting one because I think this phenomenon is more common than people think, especially in diseases where patients cycle through studies, especially in academic centres. And you know, it can be very difficult to mask the effects of efficacy. So if you have a very efficacious treatment, maybe that has side effects, patients tend to know, and patients who are inexperienced may decide not to take the placebo. And the question is pretending to take the placebo the same as taking a placebo? And I'm not sure it is, but it's a dilemma. But it's one I've come across quite a bit. And likewise, you know, I also saw in phase 2 studies that if you bring out a medicine that has better efficacy or better side effect profile, the investigators recognize it very often. So although we sort of kid ourselves that these are pure, they're not. They are an attempt to be pure. They are extremely worthy. They're vital control trials. We absolutely need them. But they aren't always the truth that they think we are. And what you're actually seeing is effectiveness playing out within the efficacy type study. So let's go to look at definitions of efficacy and effectiveness. And it's sort of tempting to think that this is a modern concept because regulators are starting to grapple with it. And it just isn't. This definition is from 1971 from Archie Cochrane, who, as you know, is probably the godfather of evidence-based medicine, visionary really. And he published this definition in 1971 in his treatise, which was Effectiveness and Efficacy. And his definitions were really quite simple. Efficacy is the extent to which an intervention does more good than harm under ideal circumstances. And effectiveness assesses whether an intervention does more good than harm when provided under usual circumstances of healthcare practice. So I think in a way this is maybe the reason why you ordered those evidence hierarchies differently in terms of scientific rigor, which we all agreed on and which the BMJ agreed on, then usefulness to inform practice. We tended to go for more towards the observational real world type data because I think we were starting to think about the patients in front of us and how that might be affect us in practice. Now, it's probably a bit more complicated than that as well, because if we think of efficacy at the center of this slide, so that's the scientifically proven benefit of the medicine in ideal circumstances, that's really where we start, isn't it? That's the evidence that we have and that regulators have in approving the medicine and deciding on its use. But in fact, in real world, in an effectiveness study, there are a large number of things that start to influence that efficacy. So the healthcare system itself will affect that. So in other words, the coverage and reimbursement of the medicine, medical practices, whether they're screening or immunization policies, diagnostic procedures. In other words, the things that enable you to get to that medicine are very big influences of effectiveness. Then on the left-hand side, you have the actual use of the medicine. So do the patients take it? Are they actually able to take it? Is it something that causes problems? And on the right-hand side, the population that you treat, which is often very different in practice than it is in the study itself. And I'll come back to that. And these interactions all come together and affect the efficacy and produce effectiveness. And that is the effect that we see in everyday clinical practice. And it is complex, and we all know that. And I think that's why you did sort of change the hierarchy when you thought of clinical practice, because these are really two subtly different things, both essential, I believe, but nevertheless they are different. Now I'm going to use a few respiratory examples just about populations in double-blind randomized controlled trials. This is a neat little study that was done a long time ago where the investigator looked at all of the patients attending his general asthma clinic in secondary care, and then he applied the typical inclusion and exclusion criteria that would apply to the usual asthma study. Those were a lung function measure, reversibility of airways obstruction, no comorbidities, non-smoker, and he applied them. And basically the lesson here was, when you applied those things, less than 5% of the patients actually would make it into a double-blind randomized controlled trial. Now, part of the dilemma here is, if you would go back to that original evidence hierarchy, we would have placed a meta-analysis of double-blind randomized controlled trials as top of the list. But in fact, what that means is we're excluding 95% of the patients in the evidence we use to decide on our guidelines, for example, which have been dominated by evidence hierarchies for many years. So it occurred to me as I went along that we needed more, because we're not looking at the patients we treat in those studies. We're looking at highly selected treatments, very highly selected patients very often. This isn't always the case, I know, but it often is the case. And then if we look at behaviours, adherence to medications in double-blind randomized controlled trials, on the left-hand side, I just picked a group of different trials. And you can see that in those trials, it's generally higher than 80%. In fact, in the phase 3 studies that I supervised at GSK, the adherence was higher than 90%. But in real world studies, on the right hand side, we see more normal adherence with treatments, which is typically less than 50%, which patients do. And I think most of us in practice, for say an inhaled therapy or a tablet treatment, we'd probably pretty delighted if we got better than 50%. But this is a very big difference between trials, because what we're asking in a randomized controlled trial is, does a medicine taken in the ideal way by patients who are able to use it perfectly, what does that produce? And in a effectiveness study, we're saying, when you let patients do what they normally do, what results can you expect to see? Now, this is a little definition I found in the BMJ from a long time ago as well, but I thought was quite a useful perspective. And it's Rowland and Torgerson. I'll just read out what they said. They said, efficacy and pragmatic trials sometimes arrive at different conclusions, either because a treatment that works in an ideal setting does not work in real life, or because improvements in a biomedical endpoint do not produce the expected health gain. They went on to say the highly controlled environment of randomized controlled trials designed to examine efficacy or safety does not reflect everyday practice. So this is perhaps obvious, but it's true to say that when we're designing trials, particularly highly controlled trials for regulatory reasons, we go to endpoints that are very important in terms of us gaining licenses or approvals, but they may not inform us of clinical benefit or translate into an expected health gain. So not only is it the environment, the patients, the behaviours, the healthcare system, but it's probably the endpoints as well that we choose and their relevance to expected health gain. There are many, many other considerations, I think, but I've just picked out a few here. One key thing is identifying responders and non-responders in big populations. If we have scientific evidence in advance of or designing a trial, of course we may identify potential responders and test that medicine on them. But very often, by excluding patients, we may miss the opportunity to identify responders in other groups. Quite a simple example of that would be there's been a long-standing view in respiratory medicine that people who smoke respond less well to inhaled steroids because of steroid resistance and impact on cyclic AMP. In fact, when there was a pragmatic trial done in asthma, which included smokers, the smokers actually got the same therapeutic response as the non-smokers. And yet that scientific wisdom had stuck for many, many years. And there are almost no studies on asthmatics who smoke and the efficacy or effectiveness of medicines, almost none, because of that thing. So these can be quite big, actually. By broadening our population, we can look at all sorts of aspects of that population and see people who may respond in a different way. And that could be behavioral, it could be biological, it could be a number of things. Safety signal identification, I think, is the other opportunity, especially early in a medicine's life cycle. Because generally speaking, picking people, very highly controlled, selected populations is not typically the way that patients ultimately get treated in terms of when they get into the elderly, polypharmacy, etc. And so the opportunity to detect signals is there sooner. And there have been some very famous examples of everyday sort of medicines that it's taken many, many years for safety signals to identify. A good example is Trilodan, the antihistamine, I think was developed in 1975, and it was something like 8 years after its launch before it was identified to have serious interactions with other drugs and also with pink grapefruit juice. And that was only when the drug was used in broad populations in elderly people in Florida, and it had an impact on arrhythmias. So I think there's big advantages in doing effectiveness studies early, and regulators like them for that reason, because it informs you of general use and better informs risk benefit and allows us to potentially identify responders and non-responders. And the final bit is implementation research. More and more, in my experience, when you go to payers and you ask them about their view on a medicine, they want to know how this medicine will fit into their healthcare system, what disruption it will cause, what cost is there, if it's a drug that has to be administered by injection or has to be observed, etc. How does that work within their healthcare system? And double-blind randomized controlled trials don't inform you of that. And I've been involved, I can't mention the drug, but I've been involved recently in reviewing evidence of drugs who failed to get reimbursement because there's been no evidence of implementation within healthcare settings. That's becoming a more and more hot topic, actually. And to me now, comparative effectiveness within a healthcare system is starting to become essential for reimbursement negotiations in many systems. So that brings me to who is the evidence for and what does that drive? And I think this has been a very significant impact on the nature of evidence that's being created. So clearly, evidence needs for today's world need to look at efficacy, risk benefit, value for money, effectiveness, and also look at the individual versus the community impact of paying for and providing a treatment or a medicine. And of course, the people interested in that are very, very broad. I mean, first and foremost, there's the regulators who are going to approve the medicine and monitor its safety with the manufacturers. The payers are very, very interested in risk benefit, community versus individual, etc., value for money. All the drug companies, of course, are interested in developing evidence to support their medicines as they launch them. Many, many countries around the world, smaller countries, are looking to larger countries for their evidence assessments and basically borrow those assessments. Physicians themselves, of course, very, very interested in how this medicine shapes up. How does it look against other things? What can they learn about its use and what to expect when they use it? Patients, more and more, I think, and patient groups are very, very interested in evidence as it's created. And of course, politicians as well now, especially with the shape of the world after COVID, are very, very interested in evidence and how it's created. But what's interesting is that each of these audiences may actually have different prejudices and views on things. And I'm not going to go into them all, but I'm just going to pick out regulators as a key group. It's pretty much to say that what regulators ask for will drive what drug companies do in terms of evidence generation, because it's a sort of chicken and egg approach. You've got to get the evidence to get your medicine looked at. On the left-hand side, this is a review of adaptive pathways for medicines development that I was involved in. It's a while ago now, 2016. But at that workshop, the proposition was that effectiveness studies, real-world data, could be an important part in adaptive pathways. And what I can say was that there was a small group of innovators who believed that that was the case, but there were far more regulators who said, no, double-blind randomized controlled trials is what we need. And I can understand why, because that's the science they know. It's what they've been grown up with. It's what they really understand, and they make very difficult decisions about licensing and approving medicines. So change has been slow. But on the right-hand side, FDA has come out with guidance on how to use real-world data, and here's an example of tacrolimus having real-world data being used to back its approval, so that the world is changing. But it's not universal, and there still is this struggle between efficacy and effectiveness and how these two things fit together, particularly in the regulatory environment. But to be quite honest, until regulators ask for more data on real world data and effectiveness, it's unlikely the field is going to change fast from a drug company sponsored study perspective. So at the heart of this, I think, and when we looked at the evidence hierarchy, I believe this is about our training. And when I think about my training, I think I was very well trained in assessing internal validity, probably really well trained in it. So the internal validity questions were the treatment and control groups representative and comparable? Was the selection allocation randomized? Were the groups similar at the start? Were they treated equally? Were they all accounted for? Was the measurement accurate? Was there blinding? Were outcomes measured in exactly the same way? And did the control group receive placebo, or it could be standard of care? So that is what I know. And when I've actually presented data at congresses, like many of you will have done, these are the questions you tend to get hammered on. These are the things that people ask because we're well trained on these. But when I think about it, when I think of external validity, I think I had far less training in this, and it's something that I've sort of acquired over time. But the questions we might ask about external validity would be, is this treatment feasible in my practice, in my setting? Is my patient so different to those in the study that the results might not apply? What alternative treatments are there available? And that might include a mixed bag of standard of care, for example. Will potential benefits outweigh the potential harm for my patients? And what does my patient think about it? You could actually add here, because this is actually an old definition, and how would this fit into my healthcare provision system? And I think, we tend to be well trained on the left, less well trained on the right, but all of us know it. And it was very interesting that when I asked you to think about predicting the response of a patient in front of you, you reordered things because we do know these things. But the regulatory world has been dominated by internal validity, no doubt about it, although that's starting to change. We can start to think of drivers of effectiveness in treatments, and these vary, of course, whether a treatment is given, say, by injection in a supervised setting to asking a patient to take a tablet. But these are the broad headings that drive effectiveness: patient acceptability, side effects tolerability, drug efficacy, the efficacy itself, of course. If a patient takes a drug and notices benefit, they may be more likely to take it. Interestingly, I think that the same applies sometimes to side effects. People feel the impact of a medicine. It can drive either way. Persistence of use, adherence itself, cost effectiveness of the medicine, especially where patients pay for this themselves. All these things play out, and there could be an overlay here as well of the healthcare professional and the influence that they have on effectiveness and the way they sell a medicine into a patient and describe its benefit or beliefs. I'm just going to look now at that question. Well, if you do efficacy studies and effectiveness studies, do you ever get different answers? I'm afraid this is a respiratory example again, but this is a typical double-blind head-to-head study in asthma comparing a new combination inhaler, an ICS-LABA, inhaled steroid long-acting beta-agonist combination, with a newer, more effective version. And this was the typical head-to-head, and this is based on lung function, change in baseline forced expiratory volume in 1 second over time at the end of the study. And what this showed was there was no difference between the two medicines, no statistically significant difference. There was no apparent benefit in the new medicine. Now, the interesting thing was that this drug was designed to be once a day instead of twice a day, and an easy-to-use inhaler. It had very long-acting molecules, and the proposition was it would be more effective in everyday practice. When that medicine was put into the Salford lung study, when the same comparison was made, looking at the comparison between the same two drugs, but looking at a different endpoint, because this was a responder analysis of people who either improved their asthma control by a clinically meaningful amount or achieved complete asthma control, i.e. remission. When you put it into this study, which was open label, in real practice, almost no monitoring over a year, patients and doctors just allowed to do what they did, there was a very clear benefit, a very significant advantage in being on the new treatment. So these studies can tell you different things. And for me, the effectiveness study wins it in terms of predicting the effect in front of a patient in front of me. Because in the first study, these patients were highly trained patients who took the device with perfect technique exactly 12 hours apart in basically a laboratory setting where they were having their lung function measured every hour almost in the waking part of the day. So this is saying to me that in a medicine taken under extreme monitoring and supervision in patients who can take it perfectly and is exactly on time, the two medicines are as good. What this study is telling me that if you put this into a general population, the effectiveness benefits of the new medicine do play out as a benefit in terms of asthma control over a whole year. So I think this is an example of how evidence can be different. There are some other things that you can pull out from these studies. The Salford lung study is a pragmatic effectiveness study. The others are big landmark studies in COPD. And if you look at dropouts of patients, in Salford, we only lost 7% of the patients. Most of those died, and we were able to keep their data in the study. But it's quite astounding how many patients you lose in some of these big studies. As high as 40%. That those patients are out, and although they'll be accounted for, we won't really know what their outcomes are. So again, big differences. So it's getting towards the end of this now, but if I was to summarize what efficacy and effectiveness studies might look like, an efficacy study to assess safety and efficacy in a controlled environment would look like this down the left-hand side. Typically double-blind, double-dummy, strict inclusion criteria, strict exclusions as well. Adherence would be encouraged at every opportunity. There'd be frequent reviews of the patients. Drugs would be provided, and we'd probably measure an endpoint that was acceptable to regulators, maybe biochemical or a physiological measure, but that's pretty typically the way it is. On the right-hand side, an effectiveness study would be open label because that's the way medicines are taken every day. In a broad population, all comers would be included. You would include the mad, the bad, the people of all social classes, all ages that would ever expect to get that medicine. Comorbidities would be included. It would be set in normal care. There would be no extra reviews, and the drugs would be prescribed and collected by the patient in the usual way. So those to me are the two sort of extremes of how we might design effectiveness versus efficacy studies. And as I said at the start, I think the two are essential, actually. Efficacy studies do tell us scientific facts, and we do our best to make it as near to the truth, but it isn't always that easy. So my final thoughts on this, really, I think my view is we do need both these types of data, and I think in the emerging world of drug approvals, comparative effectiveness is becoming essential alongside implementation evidence. We can create hybrids. We can make efficacy studies have more real-world components, and there's lots of examples of that. Examples of maybe making the control less strict, maybe extending at the end of the study to create a registry in an open label sense. A number of ways this could be done. It is an evolving field, and hats off to the regulators, to be honest, who I think have really moved fast in the last few years in identifying this and starting to take on the challenges of what this means for them. There's no doubt oncology has been key in moving on thinking. I think registries have been one of the really powerful types of evidence that could be produced in this space. And the final bit was just to say, sorry, it's been so respiratory focused, but that was my job, and that's what I've done. So I'll close there. Thanks very much.
Oh, thank you so much, Dave. That's really good, and absolutely no apology needed. So much interesting things, and actually quite interesting and refreshing for me to see it. similar ideas, but coming from a different therapeutic area. So we've got 10-15 minutes left for questions if people would like to ask them. I suggest two ways you can do this. You can either type a question in the chat box, or you can put your hand up in the just by using the reaction button. Yeah, I'll sort of try and keep track of who's doing that. So yeah, type away or put your hands up, and if you put your hand up, then I'll call you and you can come off mute and respond, ask your question like that. While people are doing that, just a quick one from me, Dave. In cancer, and you won't have seen the chat, but Piers, for example, has highlighted, there are examples of where this is happening. So Ibrance in male breast cancer. I know several people on the call will know about the importance and increasing use of real-world data as a real-world control arm for single-arm studies. So there is just a sense of the needle moving a bit. There is perhaps also a sense of the, that kind of split, mixed messages coming from regulators. But in respiratory, do you have a sense that the sea change is happening yet, that there'll be many more sulfates or whatever, or is it still a bit
I think
at
it's,
the edges?
yeah, I mean, it's probably one of the crucial questions, because I think the speed at which this is adopted is going to be so much driven by the regulators. The payers, though, are also really having a much bigger influence on evidence generation than they ever have. So I have got very recent experience where payers are actually saying, we do need comparative effectiveness data in the context of an implementable therapy within our healthcare system. So that's having an effect. Regulators themselves, I mean, I have a lot of sympathy for the regulators. I think they have an incredibly tough job. They're the people saying that a medicine is worth taking and safe enough to take. And they have a long track record of looking and assessing dossiers with double-blind randomized control evidence with similar endpoints in them. And when you come along with something that's different, they really have to scratch their heads and think. So they have such a crucial and onerous job. I think that's really why they've been slow to change. What I have seen, though, is that within different regulatory bodies, this is moving at different stages of pace. The FDA, I think, have been really key in actually producing guidance on how to use real-world evidence. In the UK and Europe, where I know it pretty well, there are pockets of enthusiasm for this. And the general response that I've come across is people say, look, we want our regulatory dossier to be defined in the way we normally see it. So we want to see those efficacy studies, but I'll tell you what, let us have a look at the effectiveness studies as well. We'll look at them and take them on board, but they won't be part of our primary consideration. So, and that has been pretty much my experience. But in disease areas where I think it's much more limited, where the disease is rarer, where it's almost impossible to use a standard of care comparator, for example, I think real world evidence is becoming key. And I would imagine oncology is one of those areas where it's likely to move faster.
Thank you. Right, I see we've got a raised hand. Piers, if you want to come off mute and even come on camera if you wish. What have you got a question? Oh, you've just put it in the chat as well. Do you want to ask it yourself, though? You're on mute, I think. No. Okay, let me read it out. And Alex, I don't know if there's a blanket mute there. So Piers' question, I have a question that is a mix of to Dave and to the group. Oncology is full of max tolerated dose optimized medicines and nasty side effects. How is that likely to impact real world effectiveness, especially between oral and IV? Patients have more discretion on those orals.
Yeah, I mean, it's such a key question, isn't it? I mean, I don't think I'd be interested to hear what other people say, because obviously we've probably a lot of people on the call who are experienced trialists as well. But it can go both ways in my experience. Where you have supervised therapy by injection or administration, so I've got some experience of that with biologicals in respiratory disease, it's generally speaking more clear cut, because I think what we see is if the patients don't like it, they don't turn up for the next dose and they can become protocol violators. But if it's a life-saving treatment, which it often is for severe asthma or for oncology, I think obviously the motivation for the patients are different. Where there are oral therapies taken at home, this is not that easy to predict because sometimes patients recognize side effects as a measure of efficacy and effect. And if they're not feeling it at all, they may be less likely to take it. This is doing no good. So I think it is very difficult to predict. But one thing that's for sure is when I'm involved in late development of drugs now, I really think in terms of what are the drivers or inhibitors of effectiveness of this medicine. And that could be everything from tablet size to taste to side effects to the perceived benefit, the sensation of taking it. I think we really have to think in those terms now. And then that'll help us predict whether in the real world this may be better or worse than what we've already got. At the end of the day, if the medicine's not taken, it's not very, it has no efficacy. And these are crucial things, so crucial considerations, Piers has pointed out. But I'd be very interested in what other people think.
Um, while people think about that, there's a question from Paul. During the COVID beginning, real-life evidence has been replacing RCTs in France, giving the example of hydroxychloroquine. It happened to have really delayed the demonstration of its ineffectiveness. Don't you think we should still do RCT first and real life second, or do you see it as
Yeah,
a whole?
yeah, no, I think that's right. I mean, I don't want to come across as a sort of effectiveness loony, the lunatic who believes that that's everything. I think that's a really good comment. I think you do need to start with efficacy in most cases. Especially with a probably a new medicine in a general class. Um, uh, you have to have sufficient evidence to believe this is going to be a benefit to humans before you can embark on doing effectiveness studies. But what I would suggest is that effectiveness should be done sooner. Salford was unusual because it was actually done pre-license, so it was done in parallel to the phase 3 program. But remember, that was a drug in a known class with a lot of safety data already amalgamated. But I think you do need that RCT evidence to be sure that you've got a good hypothesis of risk benefit and safety before you go into broader studies in most cases. I think there'll be times, perhaps in rare diseases, when that not be the case, or in very severe life-threatening conditions when that won't be the case.
That's great. Now, has anyone else got any last questions in the closing minutes? Jose. Jose, can you come off mute and speak? Let's see how that works. Oh, we can hear you.
So,
Good. Far
yes, hi.
ahead.
So it is more about this because the challenge we have with the RCTs is that when they're well designed, is everything goes well. But in cancer, we often have populations which are not representative of reality. You exclude patients over 60, which are the majority of a cancer center. And therefore, you are testing your drugs on a randomized control, which is not representative of reality. So, in the case of a little before about France, you also needed to have a rogue element in the system, right? It is, France were behind with the hydroxychloroquine because of there was an advocate which had a strong position in the scientific community. Therefore, you have a rogue element playing as well. But in this
Yeah.
particular instance, cancer, most drugs, if you are testing on the 60s, when you are testing them in somebody who's 75, the immune system behaves differently. So that's where I see that cancer is a little bit different to some of the chronic respiratory diseases that you are treating, from teenage
Yeah, no,
onwards. That's
that
where.
makes total sense to me, and what you're saying, I think applies. I mean, that I just totally agree with what you're saying. I do agree about these rogue elements and hypotheses that can emerge. I also think, that at the end of the day, drug companies tend to design phase 3 trials to win. So that because there's such a big investment in them. I don't think it's a deceit, but of course it means you haven't got the evidence for the people, like you say, the over 60s. The obvious one in asthma was the smoking asthmatics. Pretty much 20% of asthmatics or maybe more smoke, and there was no evidence to treat them. It sort of seems obvious, but yeah, there are these big gaps that appear And it's quite startling actually, because what you just said, is we use these drugs commonly in over 60s, but we generate our evidence in under 60s, and there's a sort of big gap, isn't it?
Indeed. Thank you.
We got time for one more. What's that to see? Oh, it's just a couple of comments in the chat. Okay, well, so one last one from me then. The other area that interests me, and maybe we're starting to see a little bit more on, is actually how real world evidence can help shape and construct the RCTs as well, whether it's through, actually properly understanding standard of care, or helping identify the subpopulations of interest, or, as I indicated before, actually providing some kind of control. Do you think that's a cancer specific thing? Is that something you've had a sense of in your therapeutic areas as well?
And I don't think it is cancer specific. I think actually, you've hit on quite a number of points just in that brief question, but a common dilemma is what comparator do I use, because that comparator may differ in different healthcare settings, by country, by practice, etc. And actually having comparative effectiveness data against mixed comparators can be a really useful thing to do to form the backbone of other analyses about effectiveness. So this seems to be playing out broadly in my experience in all sorts of therapy areas. And I think that's because the payers are starting to become much more interested in influencing data generation to get reimbursement. And they are interested in efficacy, but their key question is, what's this going to do in my healthcare system compared to what doctors are usually doing now? And therefore, I think it's becoming a broader question, and in lots of disease areas. I've seen it in everything from respiratory medicine through to psychiatry, through to autoimmune diseases. So I think this is emerging.
Brilliant. Thank you very much. Yeah, well, that's kind of quite heartening to hear. So I think all that remains is for me to say just a very big thank you to you, Dave. That was absolutely fantastic. So much in there. A couple of things that I'm going to really stay with me, and I'll need to reflect on. But those anecdotes about the patients, even in the gold standard double-blind RCTs, like humans, not doing what they're told, and not behaving in a way that we would necessarily think is rational. So that was good. And that shocking attrition curve of the eligibility for trials down to 5%. I mean, that really brought it home to me just quite how unrepresentative these kinds of things can be. So that and many more, lots to chew on. Thank you so much for making time to do this today. We've had well over 60 people on the call, and I'm sure lots for us all to go and think about. So have a great day. Thank you. Thank you everyone else. Those of you who aren't following DIGICORE on LinkedIn, you may wish to do that, because there's going to be more coming quite soon. So thank you all. Have a great day.
Thanks very much. Bye now.